Assalamualaikum. I'm Dr. Mohammad Ali Rabbani. I'm part 2 resident of FCPS Anatomy, and today on the forum of Medicos Academics, we are going to discuss the anatomy questions of FCPS Part 1 that relate to the region of thorax. For the purpose of this video, we are going to discuss medicine and allied portion of SK Golden 9, and we will discuss all the questions of the thorax that are present in the 10 papers present in the set section. Bismillahirrahmanirrahim. Before starting, I'll start by saying if I've seen the future, it's by standing on the shoulder of the joints. So this video has been made possible with the help of content and illustrations obtained from other sources. I do not claim ownership of any of the material that is not mine, and due credit will be given to the original source material wherever it is needed. So these are the topics. This is the outline of the today's topic. We'll discuss the osteology, then soft tissue of the thoracic wall, diaphragm, thoracic cavity, and within thoracic cavity, mediastinum, respiratory system, cardiovascular system, nerves, and other viscera that are present. So let's start with the osteology and joints. Here's a question: Xiphisternum level is what? So its level is at the vertebral level T9, and here are the three levels that you must be very vigilant about. The level of the sternum. The uppermost margin of the sternum is at the level of T2, and the most commonly asked question is this one: the sternal angle, sternal angle, angle of flow is at the level of disc between 4 and 5, and the xiphisternal joint and xiphisternum itself is at the level of T9. And the important thing to remember here is you should very much be vigilant, and you should remember the structures that are passing through this imaginary line that is passing between the angle of Lewis and the intervertebral disc between T4 and T5. Ribs are most commonly fractured at they are most commonly fractured at the angle of the rib. Reference from the BD Trachea. Let's discuss the thoracic wall soft parts. Increasing transverse diameter of the chest. Before I go into the detail, in that event of inspiration, the increased thoracic volume can be obtained by increasing anteroposterior diameter, transverse diameter, and the vertical diameter. The vertical diameter is known as piston movement, and that is done by diaphragm. The transverse and anteroposterior diameters in the quiet inspiration are mostly they are done with the help of external intercostal. In general, both help in both the movements, internal and external. They both help in inspiration and expiration, but external intercostal is more active in inspiration and intercostal is more active in expiration. And the other thing you need to remember is that the transverse diameter that increases, it is due to the bucket handle movement, and the anterior posterior diameter that increases, it is due to the pump handle movement. And we are here discussing the quiet muscles of inspiration. If we do go for forceful inspiration, accessory muscles get involved. I'm not going into that detail right. Transverse diameter of the thoracic cavity increased by exact same question, external intercostal muscle. And repeat it again. Muscle increases the lateral diameter. That's the same meaning. Transverse diameter, lateral diameter. So that's external intercostal muscles. So a needle in the lower margin of the rib, which is the first structure to be damaged. For this purpose, you must be knowing the structures present in the subcostal groove and their arrangement. The most superior one is vein, the most inferior one is nerve. And when a needle is passed through the inferior margin of the rib, the most vulnerable structure is the intercostal nerve. The nerve is most likely to be damaged. And here you must know the difference between the rib and intercostal space and be very vigilant while reading the stem. So here the nerve will be damaged when you are passing the needle at the lower margin of the rib. When you pass through the upper margin of the rib, it will involve the collateral branches that are very minute and they have very less functionality that are not missed as much as the main nerves. So when the needle is passed through the lower margin of the rib, intercostal nerve is damaged. But same question can be asked with reference to the intercostal space. When the needle is passed, this is the hole in the intercostal space covered by the muscle. When the needle is passed to the upper margin of the intercostal space, the nerve gets involved. So be very vigilant about reading the question that you are being asked about the lower margin of the rib or upper margin of the intercostal space. They try to confuse in that aspect. A student is dissecting at cadaver and now just behind and parallel to the sternum. Just behind and parallel to the sternum, this is the artery that goes. This is known as internal thoracic artery, internal memory artery, or parasternal artery. All are the names of this artery. Most commonly used name is this one, internal thoracic artery. That is mostly used by anatomical nomenclature. Collateral branches of intercostal nerve. So the um, give lateral cutaneous branches? No. The lateral cutaneous branches come from the main intercostal nerve. They run in subcostal space? No. They run in the lower portion of the intercostal space, not in the subcostal space. They run in intervertebral foramina? No. They emerge after the nerve has exited intervertebral foramina. And the supply muscle, this statement is true. So this will be the correct answer. So here is the collateral branch of intercostal nerve running along the lower aspect of the intercostal space or upper aspect of the rib below. Diaphragm. Diaphragm is a very important topic for exam point of view, and the important thing that you need to remember about diaphragm, it's almost everything. You need to remember the openings, especially the three major openings and the structure passing through them and the level of those openings. The muscular and the motor and the sensory nerve supply of the diaphragm, and more than that, you need to know the attachment of the diaphragm, especially on the posterior aspect. Let's see. Posterior hiatus, which structure passes? Posterior hiatus is the opening of the aortic opening. Which structure passes through aortic opening? That is aorta, thoracic duct, and azygous vein. So this is posterior hiatus. Then here is aorta, here is azygous vein, and here, in between them there is thoracic duct. Phrenic nerve evolves just at its origin. What structures will be lost? So phrenic nerve for the diaphragm, it helps in complete motor supply of that half of the diaphragm. So when the phrenic nerve is involved, the ipsilateral pulses of one side of the diaphragm will occur. Here, the phrenic nerve has been shown in red color. If this nerve is damaged, the whole muscle mass of the diaphragm on one side of the midline will get paralyzed. Why others are not okay? Loss of respiratory reflex, no respiratory reflex will intact, and they will be elicited by the whatever is the remaining musculature of the inspiration is there. There will be loss of inspiration, no thoracic cage diameter will continue to increase. The other diaphragm will help somewhat, it will compensate. Loss of sensation of the central part of diaphragm, that will again be not true. If the statement has been the loss of half of the central part, it may be partially correct, but because other half is still intact, it just says the front nerve is avulsed, one front nerve is avulsed. And the other thing is that whenever there is sensory innervation, there are no sharp demarcation. The area of supply usually overlap one another. Thoracic aorta passes posterior to. I just talked about the posterior attachments. You should be very well aware of the posterior attachments of the diaphragm. Here, the diaphragm is attached with the help of two crusts, right crust from L1 to L3, left crust from L1 to L2. Between the two crura, there is this median with N arcuate ligament, and then from L2 on right side and L1 body on left side, the ligament goes to the transfer process of L1. So this arch is known as medial with L arcuate ligament. And from this transfer process of L1 to the last rib, 12th rib, this part of the diaphragm, this tendon is known as lateral arcuate ligament. So there is median with N arcuate ligament, medial arcuate ligament, and lateral arcuate ligament. So the median arcuate ligament, that is making the opening of the aortic opening. So here is the aortic opening. Thoracic aorta passes posterior to median arcuate ligament. In the escapal, this reference is given down below. The key is mentioned medial arcuate ligament. You should correct it. The thoracic aorta is passing posterior to median with an arcuate ligament. Okay, the correct answer is this one, median arcuate ligament. But and you should also know the structure which are passing below the rest of the ligaments. Below the medial arcuate ligament, here, let me mark it for you so that you may have visual affirmation. So this is wrong. This is the correct answer. Okay. Now I was talking about this. What are the structures that are passing beneath the medial arcuate ligament? You should remember the muscle, that is vas major, and there is sympathetic chain. And beneath the lateral arcuate ligament, here it is shown like this. Beneath it passes the quadratus lumborum and the subcostal artery nerve and vein. Thoracic cavity. Thoracic cavity, on the either side there are lungs that are pleural cavities, and in between them, whatever the space that is left between the lung, that is known as mediastinum. So you should be very much aware about that how the mediastinum is divided. So mediastinum is divided into two parts. Upper part is above the imaginary line that is passing between the angle of Lewis and the T4 and T5 disc, and that is known as superior mediastinum, and below that is inferior mediastinum. In the inferior mediastinum, the major structure is pericardium. Everything inside the pericardium is known as middle mediastinum. Everything anterior to the pericardium is known as anterior mediastinum, and everything posterior to it is known as posterior mediastinum. Open a book and memorize all the contents that are present in all the mediastinum chambers or mediastinum segments. So the obstruction of thoracic aorta will lead to, so if there is thoracic aorta lead, there will be leakage of lymph fluid, and that is known as chylothorax. Contents of anterior mediastinum. You should memorize the contents. It's very important. Anterior mediastinum has the major component is thymus gland. So thymus is the major component of the anterior mediastinum. Other structures are pericardial ligaments, and there are some fat, some lymph nodes, and some branches of the internal thoracic artery. Structures present in posterior mediastinum. Again, you should know the contents. Here in this particular MCQ, two options are correct. The answer that was given in the key is descending aorta. As it's the most prominent structure, you can give it highest priority. It is alright among these options. This is the best answer. But there is one more answer is correct. Guess it. If you have thought it right, the vagus nerve is the correct answer. As vagus nerve, it passes through the superior mediastinum, it passes onwards to the posterior mediastinum, and you must remember that it passes on either side of the esophagus, then it passes anterior and posterior to the esophagus, and through the esophageal opening enters the abdominal cavity. So these both are correct, but because descending aorta is such a huge structure that is present here, you can give priority when both are given in one option. Nerve immediately lateral to the trachea. So this is one of the controversial question that people are confused between recurrent laryngeal nerve and vagus nerve. Even yesterday or day before yesterday, there was a whole debate going on Facebook page regarding the correct answer of the two. So here you must understand that this is a either purely made MCQ, or it was originally a good MCQ that has been rendered in this very structure after poor recall. So these both options can be correct, and it totally depends upon the scenario. So if we look at the level of the neck, so when we look at in the neck where the thyroid gland is around the trachea, here here this is the recurrent laryngeal nerve that is immediately posterolateral to the trachea, and even some aspect it is even just lateral to the trachea also. So there is a variability that it may be posterolateral and it may be lateral to the trachea. And at this place, the vagus nerve is all the way over here within the carotid sheath between internal carotid artery and the internal jugular vein. So at this point, if we say if the scenario indicates that we are talking about in the neck at the level of thyroid gland, or the scenario is something like that, and where during surgery a general surgeon opens up the pretracheal fascia for the removal of thyroid gland, at that time he identifies recurrent laryngeal nerve. What is its relation with the trachea? Now you can say that recurrent laryngeal one is the one that is immediately lateral to the trachea. Vagus nerve is all the way over here. So in the neck, the true answer will be recurrent laryngeal nerve. But if we go to the thorax, let me zoom it for you. It's a little different. In the thorax, the story is little different for both the right and the left side. On the right side, if you can see my cursor, on the right side, the vagus nerve, the main trunk of the vagus nerve, it actually moves across the lateral surface of the trachea. Here you can see that. So it does have a lateral relation to the trachea. But this is true only for the right vagus. The left vagus is separated from the trachea by the arch of aorta and its subclavian and internal common carotid arteries. So whether what answer is correct, this is the recurrent laryngeal one is given in the key, and vagus nerve I am also advocating it. I'm just saying you should know the story and should wait for a good mid MCQs, and in any MCQ you will be given a hint about what they are asking and where they are asking about. If we are talking about in the neck at the level of thoracic gland. Then we are talking about recurrent laryngiana. And if we're talking about superior mediastinum in the thoracic cavity, then the lateral relation is to the vagus nerve, and to be more precise, it is only to the right vagus nerve. I hope that makes things clear. Bifurcation of the trachea occurs at the level of, it is at the level of T4 and T5. I'm going to focus it on again that open a book and make a list of all the structure that are passing at the level of T4 and T5. Immediately I can remember there is bifurcation of trachea, there is um, terminal part of ascending aorta, there is start and end of arch of aorta, there is a level of ligamentum arteriosum, level of origination of recurrent laryngeal nerves, the start of descending aorta, and then there is the level where thoracic duct reaches the left margin of the esophagus. Then there is the point where esophagus will enter the superior vena cava, and there are one or two more. I'll just encourage you, if you open the book, make a list and memorize it. That particular concept is asked repetitively in the examination. The normal resonance at the back of the neck can be felt at the level of. So here in this particular question, the correct answer is T10, 10th rib. For this particular question, you should have a very good knowledge about the surface anatomy of the lung. For the purpose of CPSP examination, you don't need to memorize whole of the surface anatomy, but you must be very careful and very clear about the lower margin of the lung and lower margin of the pleura. So here it is. So we see the lower margin in three lines: in the mid-clavicular line, in the mid-axillary line, and just on either side of the vertebral column or paravertebral, or you can say that in the back. So at the mid-clavicular line, it is at rib number 6. At mid-axillary line, it is at rib number 8. And just near the posterior midline, it is at the rib number 10. So the lower margin of the lung is at the 6, 8, and 10 rib levels at mid-clavicular, mid-axillary, and posterior midline. So these are the lower margins at till where resonance will be found and the percussion. So if you percuss, you will go up all the level of the 10th rib where you can find the percussion resonant sound. So this is asked another way. It's a very clever question, and if you had that idea, let me go back to that. And the same thing about the lower margin of the pleura, you should know. So the same thing about the lower margin of the pleura, you just have to add the number 2. So at midclavicular line, it is at 8th rib. At here, you can see that it is at 8th rib. At mid axillary line, it is at 10th rib, and the posterior midline, it is at the 12th rib. So the lower margin of the pleura is two spaces below the lower margin of the lungs. So whenever you have to access the pleura without touching the lung, it is safe to it is that is why it is important to know the lower margin of the lung so that you can reach the lower margin of the pleura without injuring or puncturing the lung. So here I said that this is a clever question. Pleurosynthesis safe side. So even if you don't know from your background, clinical background, you have not got it memorized, but you should solve it by common sense. So in the ninth intercostal space in mid-axillary line, in the ninth intercostal space, in the mid-axillary line, the lung enters finishes at the eighth intercostal space, and the pleura finishes at the 10th intercostal space. So yes, ninth intercostal space is a safe space for pleurosynthesis. But now there are two ninth intercostal space in mid-axillary line. There is upper border of intercostal space, and there is lower border of intercostal space, and there is upper border of intercostal space. So which one of them to choose? So you saw that whenever you go to the upper border of the intercostal space, you are risking the injury of intercostal nerve. The safe bet is going to the lower border of the intercostal space. So the correct answer here will be lower border of the ninth intercostal space in mid-axillary line. And in ninth intercostal space in mid-clavicular line would not be a correct answer because the pleura ends at the eighth intercostal space in mid-clavicular line. If you go below that, you are not going into the pleura, you are just going into the abdominal cavity. Elongated airway has alveoli in abundance. Alveoli starts to appear in the respiratory bronchioles and they continue on to the alveolar respiratory bronchiole. They continue on to the alveolar duct and alveolar sac. Both alveolar duct and alveolar sac have a large number of alveoli. But in this question, the elongated airway. Elongated airway will be alveolar duct. So here alveolar duct is shown, and along its wall it is filled with the alveoli. Here the alveolar sac is just like a balloon, and on the surface of this there are hundred of microballoons on the surface. So it is the alveolar sac. So it is not an elongated space. This one is an elongated space. So elongated airway with alveoli in abundance is alveolar duct. And these are the respiratory bronchioles where first alveoli starts to appear. And the terminal bronchioles are the first one. The terminal bronchioles are differentiated from the respiratory one on the presence of this alveolus. In the terminal bronchioles, the special thing about them is that they do not have the cartilage in them. The right-sided decreased breath sounds, trachea shift to the left, diagnosis will be, it's a simple one. That's a pneumothorax, right-sided pneumothorax. Actually, it's tension pneumothorax that have left to pushing of the mediastinum towards the opposite side. By the way, this X-ray does not match the side of the question, so don't get confused by that. Lung collapse inwards, chest outwards, diagnosis again, tension pneumothorax. Same question. What about the lung? It's true. Absent substance fascia? No. Both the lungs have substance fascia. Four pulmonary veins? No. There are two pulmonary veins per lung. Has four bronchopulmonary segment? No. There are 10. Azygous vein is in direct relation. Yes, azygous vein is directly related or superiorly related to the root of the lung, or it is related to the mediastinal surface of the lung just above its hilum. Which structure passed arches over the root of the lung? Again, same question that was in the previous one. The correct answer should have been the azygous one. But the interesting thing is that here the answer did not have right phrenic, right vagus, esophagus, and esophageal. Okay, this is the question. Before making the video, I actually dwelled on it a lot. I think some mistake have been made, but even if the mistake has not been made, in my humble opinion, here is the phrenic nerve going on the right side of the vena cava and going on the side of the pericardium. And here's the root of the lung. You can see from this picture, it does not have any superior relation to the vena cava, to the hilum of the lung. But vagus nerve do have, it does seem to have a relation to the um, root of the lung. I actually scanned books in the last, in the even in the Gray's Anatomy, it is not written in the text that vagus nerve has a superior relation to the root of the lung, but it is written that it crosses the azygous vein at is passing over the root of the lung. From this point, we can say that it the vagus nerve can be said to be in the superior relation of the hilum, but the vagus relation is known for its posterior relation. So I think that is a poorly constructed MCQ. They did not take in account of the confounding factors, but still, if you have to pick one of them, my choice will be the vagus nerve, not the phrenic nerve. My choice. At least it's my humble opinion. If you have any good reference and if you have any other argument, please do mention in the comments below. So otherwise, you should know that anterior relation mostly it's the phrenic, posterior relation is of the vagus, and superior relation is of the azygous vein, and inferior relation of the pulmonary ligament. So which tributaries will dilate as a result of lung tumor compressing azygous vein? So if the esophagus vein is compressed, you should know the structures that are making the esophagus vein. So there will be a right uh, esophagus vein is on the right side, so right ascending lumbar. The esophagus vein is made up of ascending lumbar vein, lumbar esophagus vein, and subcostal vein. These three veins they join to form the esophagus vein. And as the esophagus is on the right side, so the answer will be right ascending lumbar. Bronchial artery right side arises from. Bronchial artery can arise as a direct branch of the aorta, but in lot of cases it arises as the branch of third posterior right intercostal artery. So here is a third right posterior intercostal artery going and crossing the midline, and while it is crossing the midline, it gives one branch to the bronchial artery. So bronchial artery right side arises from third posterior intercostal artery. Here is a reference. Last is given. The netter image is right in front of you. Please correct the key in the given question reference so that you may not get confused when you go and revise the other time. Bronchopulmonary segments. Bronchopulmonary segments are repetitively asked, and this is a part of the exam that is asked a lot of times. So the correct segment is they're drained by bronchial veins. They are drained by bronchial veins. They are supplied by unpaired artery and bronchus. They are basically artery and bronchus are paired actually. The term for non-necessary reason. No, they are very necessary classification. Aired by secondary bronchial. No, it is aired by tertiary bronchial. This is a functional unit of the bronchopulmonary segment. Its apex is towards the hilum of the lung. Its base is on the surface of the lung. On it enters the pulmonary artery, segmental bronchus or tertiary bronchus, and along with it there are bronchial arteries. They go in, all of this exchange take place, and the veins do not leave through the center. The veins are shared between adjacent bronchopulmonary segments. So veins and lymphatics are on either side of the bronchopulmonary segments. Supine position foreign body will go to. This is a very frequently asked question. Its answer is apical segment of right lower lobe of the liver. So I'm giving the reference. If you have any confusion, if you want to give it to someone, here is a solid reference is given. The reason behind it is that most of the bronchi, they are segmental bronchi, they are exiting from the lateral surface or anterior surface or medial surface of the main bronchus. But only here it is shown in the purple, the segmental bronchus that is supplying the um, superior uh, l- segment of the lower lobe of the right lung and even for the left lung, it is the only one that is exiting from the posterior aspect of the main bronchus. So if it is exiting from the posterior aspect, so if a person is lying on his back, so anything that enters the main bronchus, it has chance to go into the this one. And the other thing, it joins with the knowledge that right main bronchus has more chances of receiving a foreign body as compared to the left main one, because the right one is shorter, wider, and straighter. This question is asked again and again. Apical segment of right lower lobe, and yes, bronchopulmonary segment is supplied by. You should know the differentiate between primary bronchus, secondary bronchus, and tertiary bronchus. So bronchopulmonary segment is supplied by tertiary bronchus. So what are they? When trachea divides into two, so these are known as primary bronchus. This is the first bronchus that is ever formed. So, and when this primary bronchus goes on, in the right lung, there are three lobes. In the left lung, there are two lobes. The part of the bronchus that goes to each lobe, that is known as secondary bronchus. So, in the right, on the right side, there will be three, one, two, and three, and then in the left side, there will be two secondary bronchus. And each secondary bronchus will then divide into further bronchi, that will, if one bronchus will go to the one segment. So those segmental bronchus are known as tertiary bronchus. So the primary bronchus is also known as principal bronchus. Secondary bronchus is also known as lobar bronchus, and tertiary bronchus is also known as segmental bronchus. Here you can see tertiary bronchus is here. This question is asked a number of times. Bronchopulmonary segment aerated by, broncho segment is supplied by. So the reference are given below. So these are asked a number of times, at least in the golden 9 files of the medicine and allied. Part of the lung adjusts itself in the costomediastinal recess during respiration. So costomediastinal recess is along the anterior margin of the lung. Costodiaphragmatic recess is along the inferior margin of the lung. So here you should know what structures of the lung are at the anterior margin of the lung. So here these are the lingula. Here you can see that in these are the superior and inferior lingular segments. These are near the anterior margin of the lung. So these are the one that goes into the costomediastinal recess in the time of deep inspiration. Now move on to the heart and pericardium. This is one of the maybe the most important topic of the thorax. You should remember each and everything about them, especially their circulation. So you can leave nothing in the heart. You have to do it, all of it. Anterior surface of the heart is mainly formed by, the most important structure in the anterior surface is the right ventricle. Here you can see most of the anterior surface is made up of right ventricle. Rest of it is made up of right atrium and auricle, and here a small part, a small slip of left ventricle is there. But the most important one here is the right ventricle. Anterior surface of the heart, same question, same answer. About right ventricle, which statement is appropriate? So they did not give the answer in this particular part. So the statement that is appropriate about it is that pulmonary trunk arises from it. Mitral valve area. Okay, you should know when we are asking about the surface anatomy and the area, we are mostly asking the areas of auscultation. In clinical anatomy, the actual surface anatomy of the four valves of the heart are not so important. What is important is where you can best hear the sounds. So the mitral valve is at the apex. You know apex from the apex beat from the clinical examination. So it is the left side of the sternum, fifth intercostal space, mid clavicular line. Sometimes it is written as medial to the mid clavicular line. Sometimes it is written as 9 centimeter from the midline. So it is fifth intercostal space, 9 centimeter from the midline or in the mid clavicular line. So here is the point where mitral valve can be heard. Where tricuspid valve can be heard fourth intercostal space just lateral to the sternum. Aortic valve is heard at second intercostal space just to the right of sternum. Pulmonary valve is heard at second intercostal space just to the left of sternum. So all of the other surface marking are shown in green. Actual surface marking, I'm not going into those details. Atrial arterial supply of the interventricular septum is anteriorly it is supplied by left anterior descending artery that supplies two-thirds of the interventricular septum. Posteriorly, it is being supplied by the posterior interventricular artery that supplies one-third of the posterior interventricular septum. So they have not given a combination. So we will go for the one that gives the most blood supply to the ventricular septum. That will be anterior interventricular artery. And anterior interventricular artery here it is a branch of left. It is actually a branch of left coronary artery. So it is the anterior left anterior. It is also named as left anterior descending artery or anterior interventricular artery. Posterior one third interventricular septum infarct artery involved be posterior interventricular artery, and posterior interventricular artery in 90% of the cases is branch of right coronary artery. Here you can see right coronary artery. It goes all the way from the anterior surface, goes to the inferior surface, and here it makes the posterior interventricular artery. And the artery that is, it also supplies the AV node. Blood supply of the interventricular septum. Again, the same question. Interventricular artery. The infant's SA node is 60% of the time supplied by SA node and AV node. Most of the time they are supplied by right coronary artery. Sorry, in infants, I'll comment in the section, but I think I have on very solid ground that it is on in the last clinical anatomy. It is written that SA node is in the 60% of the cases supplied by right coronary artery. If you have any reference against this answer, left coronary artery, please do give me in the comments. But what I know, what I have read, and the recent most book I read about the coronary circulation was Last Clinical Anatomy. In that, it said that right coronary artery supplies the SA node in 60% of the cases. But if you have reference about this, please do give me. I'm also in the learning phase. Left circumflex artery is blocked. It will lead to infarct of. So these are interesting questions. SA node, AV node both are dominantly supplied by right coronary artery. So these are out of question. Uh, right ventricle, it is dominantly supplied by right coronary artery. It is out of question. That we are left with this one, left atrium and left ventricle. So this is the left circumflex artery. It supplies most of the left ventricle anteriorly and even posteriorly, and it gives branches to the atrium above also. So you can pause the slide here, take a screenshot. I have tried to make a summary of the blood supply, and my major source was, at least while making this slide, Snell's anatomy. So you can see that which are the structure that are being supplied by the right coronary artery, which are the structure that are being supplied by the left coronary artery. The blood supply of epicardium is basically the visceral layer of serous pericardium, and it is being supplied by the coronary arteries. That's not such a tricky question. Which vessels drain directly into the right atria? Most of the vessels, the great cardiac vein, middle cardiac vein, small cardiac vein, they go into the coronary sinus and then through them to the right atrium. But there are anterior cardiac veins. Here you can see that are on the anterior surface of the ventricle that go directly open into the right atrium. The coronary sinus is not actually a vessel, it's a sinus. That's why we're not superior. Actually, Mm, these are not very good distractors actually. Coronary sinus do open it directly, superior vena cava do open directly, inferior vena cava do open directly. So again, this is a question that needs to be reformulated a little, but still you get the idea which vessels drain directly into the right atria. They are basically asking about the coronary circulation. So go ahead for anterior cardiac vein. I hope will have a strong distractors in the case of your main exam. Cardiac plexus is formed by it is majorly formed by this vagus nerve, but this again is made up of both things. Again, this is not a very good made question because here you can see that I have entered a picture of netter. Here it is the this one. This is the vagus nerve. So both the right and left vagus nerve they are contributing. The fibers are shown in purple and black. Purple one are parasympathetic fibers. Black one are sensory fibers. So both go into the cardiac plexus. Similarly, T1 to T4 both go into the cardiac plexus. So the statement that is entirely true would have been both vagi and T1 to T4. So बाकी सबको जबरदस्ती का है कि अगर आपने किसी एक को करेक्ट करना है ठीक है तो लेफ्ट वेगस को करेक्ट करते हैं उसका कंट्रीब्यूशन थोड़ी ज्यादा है बट आई विल गो फॉर T1 to T4 क्योंकि ये it is a very well established fact that T1 to T4 are the one from which sympathetic supply is one, and these are the one that receive the pain nociceptive stimuli. Here they are shown in green color. So T1 to T4 they receive the sensory stimuli, and due to that, these are the dermatomes in which you feel the angina pain. So my preference would be T1 to T4, but I sincerely hope that such weekly made MCQs are not there. When you say the word weekly made MCQs, you rely on your knowledge, you rely on your preparation, in actual MCQs, there are less some mistakes like this. The people who have compiled these books, they have done a wonderful job, but you have to acknowledge the recall factor. You have to acknowledge the human factor. When you recall, a person is mostly fixated on the correct answer. Okay, so there was a question about cardiac plexus, and the correct answer was left vagus nerve. So the other distractors were filled in later on without giving that much thought. So that's why you get questions in the review books where more than one questions are correct. But in actually this happens very less likely in actual examination. Parasympathetic supply of the heart is through the vagus nerve. Yes, sympathetic supply is T1 to T4, T5 तक भी हो सकती है. Conducting system of the heart is located in. For some reason, it is very favorite question. It is located in the subendocardium. It is located between the endocardium and the myocardium. So it is asked again and again and again. Pneumothorax senses high CVP is when there is pneumothorax, there is less return to the heart. And for a person who have worked in anesthesia, you must know that you measure the CV line both mostly through the clinical examination without passing the cannula, usually through internal jugular vein. But when you pass the cannula, you can measure it through both the internal jugular vein and uh, subclavian vein. So in the key, the answer was mentioned subclavian vein, but here the subclavian vein was mentioned in the key. But I would like to suggest right internal jugular vein because actually what happens is central venous pressure it does raise in all of them. It is raised in left internal jugular, it is raised in right internal jugular, subclavian vein. You can exclude external jugular vein because it has multiple valves. Now, why I'm giving preference to the right internal jugular vein? Because the right internal jugular vein is in straight line with the right atrium, and due to that reason, in clinical examination, in even the bedside, Professor Dr. Anatollah bedside, it is mentioned that it is the one that is used to measure the central venous pressure. So my preference would be right internal jugular vein, but I would very much like to welcome any of you for such a controversial MCQ. If you have a good reference, please do mention. I will incorporate in the next videos. Deep vein thrombosis first goes to. Here the first is the key answer. So deep vein thrombosis, when it moves from the leg, it first goes to the inferior vena cava. ठीक. So inferior vena cava will be the answer due to the first. Otherwise, after the inferior vena cava, it goes to the right atrium. After that, it goes to the right ventricle, and after that, it goes to the pulmonary arteries. If there is a deep vein thrombosis, ultimately goes into the pulmonary artery and its branches, and pulmonary embolism occurs. Thoracic duct opens into the junction of internal jugular vein and subclavian vein. So here at the junction, it may open directly into the subclavian, directly into the internal jugular, but most commonly into the angle between the two. Near ligamentum arteriosum, the structure is present that is recurrent laryngeal nerve, left recurrent laryngeal nerve. It hooks around the anteriorly, it passes anterior to the ligamentum arteriosum. So these have been all the thorax question. For the esophagus question, you can follow the video that has already been uploaded about the abdomen and pelvis. All of the thoracic question of the esophagus were included in that also. Thank you so much for seeing the video. For any more videos and updates, please follow our Facebook page, subscribe to our YouTube channel. And if any further questions, suggestions, or complaints you can regarding this topic or any other, please don't hesitate to comment below the video. And you can always contact us through our page, through Messenger, and through the WhatsApp number that is present on our page. Thank you so much. See you inshallah in the next video. Allah Hafiz.